Septicemia is different than bacteremia, viremia, due not only to the presence of an organism in the blood, but the flourishing of that organism. Bacteremia is the presence of bacteria in the blood. We don't know if the bacteria has established an infection yet. We don't know if the bacteria is multiplying. Excuse me. But if that bacteria is able to establish itself, maintain its numbers, if not increase their numbers, we are now in the realm of septicemia. There are numerous bacteria and fungi that can cause septicemia. So we're not going to sit here and say, oh, here's the top ones, because it's too numerous. You'll see that instead of calling it septicemia, many clinicians will refer to this as a patient being septic. Patient suffering from septicemia or patient who's presenting as septic are going to have a fever. Okay, they're going to be very ill, sweaty, very cold to the touch, almost shock. For some, they're going to have an altered mental state because the bacteria, the virus, the products, the waste products and whatnot are going to be interfering with the function of the brain, altering brain chemistry. For some, there's going to be gastrointestinal symptoms, stomach aches, diarrhea, and this could be due to, the source of the microbes getting in the blood could be from an injury in the GI tract, or it could be altered blood flow to the intestines is causing altered flow of the food through the gastrointestinal tract. I referred to this just a few minutes ago as shock-like. Well, it's because low blood pressure due to low blood volume is a hallmark to this. So in a clinical setting, a patient presents, either they tell you or somebody else who's, their advocate tells how they've been sick, they've been shaking, the chills, having trouble maintaining a conversation, having to stop, losing track of where their thoughts, which is abnormal for them. They have a fever, and this isn't going to be a low-grade fever. This is going to be 100, 101, 102 fever. And their blood pressure is lower than normal. Okay, those are the hallmarks for them being septic. If this progresses, the low blood pressure, the shock, can lead to the beginning of cellular damage. Cellular damage leads to tissue damage leads to organ damage. Enough organ damage accumulates, you end up with death. As I said in the first slide of this lecture, there are numerous bacterial causes, numerous viral causes for septicemia. Here in the States, MRSA is a common cause. MRSA, methicillin-resistant Staphylococcus aureus, going to get into a wound, or it's going to be able to penetrate epidermis, dermal layer, get into the capillary beds. We also find what they refer to as polymicrobial infections. Numerous bacteria get in due to a wound or a surgical site. The problem we find is that if it is a gram-negative bacteria that is causing this septicemia, antibiotics will remove will damage, if not kill, the gram-negative bacteria within 12 to 36 hours. Okay. But the bacterial cells, the whole time they're there, even upon death, are releasing endotoxins into the bloodstream. So where the presence of the bacteria was bad enough, the release of the endotoxins can lead to endotoxic shock, which is much, much worse. It's harder to get those endotoxins out of the bloodstream. It takes much, much longer. We see the same thing, forms of endotoxic shock associated with some gram-positive bacteria, specifically Streptococcus pyogenes and Staphylococcus aureus. Uh, we see in a clinical setting, IV lines and surgical procedures are the most common means of transmission, of getting the bacteria into the bloodstream. Lesser extent, urinary tract infections, some form of abscess. The urinary tract infection goes up into the bladder, in bladder to the kidneys. So bladder infection, kidney infection will create an abscess. That bacteria, the pus collects there. You get breakdown of the tissues in those areas. Bacteria get access to the blood. Same thing with the pancreas, the gallbladder. Gallbladder, bile normally would collect from the liver to the gallbladder into the small intestine. The bile goes in there to aid in nutrient uptake, aid in digestion. But sometimes you get the gallbladder gets backed up, or there's some form of a blockage. Then that normal flow out will allow for food and bacteria to ascend up to the gallbladder, get an infection there, leads to an abscess, and so on. Diagnosis of this is going to start with the symptoms and signs that a clinician would notice in the ER, in the clinic. Once you notice low blood pressure, the shakes, the chills, the fever, take a sample of the blood, send it off the ID lab. They can begin examining, do a blood smear, gram stain a blood smear, look for the presence of microbes in the blood smear. Then once they say yes, septicemia, or at least bacteremia, then tell the clinician starts antibiotics. ID lab, after that initial information is given, will then start culturing. Start culturing the blood, see which bacteria is present. What antibiotics are they still susceptible to? For prevention, really, there's not much you can do. If somebody's going to be in for surgery, many clinicians will start broad spectrum antibiotics, just just in case. Going to be cutting them open, things like that. So you want to make sure that any bacteria that's introduced into the wound will be immediately taken care of. Treatments, basically antibiotics and supportive care. Keep the blood volume up as much as possible with either saline solution or blood transfusion if necessary. And once the antibiotics are started, keep an eye out for endotoxins in the bloodstream and endotoxic shock.